Get ready to invest in yourself and elevate your expertise with the Perio School podcast, brought to you by Perio School. It's Dr. Reena here, and you're joining us for a new monthly show where we'll be providing the latest case studies, first-hand insights, and interviews with our global dental network. Plus, we'll enable you to experience exclusive behind-the-scenes highlights straight from our global portfolio of courses. Let's get started. This season of the podcast is sponsored by Kiroku, an AI assistant built specifically for dental professionals and one we've used for years. Kiroku listens to your appointments and turns chairside conversations into accurate clinical notes, referral letters, and treatment plans in minutes. What used to take hours now happens straight after the appointment. No late evenings catching up on notes. You can start a free trial at trykiroku.com. And if you'd like exclusive discounted access, email us at hello@perio.school. Today's masterclass is about dentine hypersensitivity. So what is dentine hypersensitivity? Well, the classic definition is dentine hypersensitivity is characterized by a short, sharp pain arising from exposed dentine in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, which cannot be ascribed to any other form of dental defect or pathology. So it's basically a diagnosis of exclusion. And in terms of how common it is, a practice-based study by West et al. In 2013 of 18 to 35-year-olds found an incidence of 42%. So that is high. So I think it's one topic that we do need to cover. It's one that we need to think about in our daily practice because it can be distressing and it can affect quality of life of our patients. The etiology can be attributed, and I'm sure you remember from university, the Brandstrom's hydrodynamic theory, and that describes the fluid movement within the dentinal tubules. For dentine hypersensitivity to occur, you actually need two things. You need dentine exposure, and that's actually termed as lesion localization, and tubule exposure, and that's better termed in terms of lesion initiation. So lesion localization can occur through soft tissue loss from gingival recession or hard tissue loss from abrasion and erosion. And lesion initiation can occur through abrasion or erosion. So dentine hypersensitivity, if we're talking about perio patient, it is not uncommon, and it can also present following periodontal treatment as well. So I've said before in our masterclasses, we need to be a detective when it comes to treating perio patients and conditions like this. So the first thing you need to figure out is, why has my patient got dentine hypersensitivity? And this might include, home care issues. They might have periodontitis. They might have abrasion. There might be something in their diet. So because when you do the treatment plan, we're going to need to hit those factors to fully address their dentine hypersensitivity. For example, you might want to go through appropriate home care regimes. If they're brushing too hard, overzealously, that's causing abrasion, that's causing recession, you need to go through that, a gentle but thorough technique. If they've got periodontitis, that can lead to sensitivity, so we need to treat that. If they've got something in their diet that's very acidic frequently throughout the day, that needs to be addressed. If they've got any reflux, and some people, they may not be aware of it, or they might just got a little bit of heartburn, but actually that constant acid attack internally is causing persistent sensitivity. Or if they're grinding their teeth, maybe they need a mouth guard. So I think sometimes it's very easy just to think, oh, you've just got sensitive teeth. But actually, it would be so much nicer for our patients if we can give them a range of things we can do to actually try and help them. When you're thinking about sort of at-home products, obviously go for ones that are evidence-based. There are lots of over-the-counter products out there in terms of toothpaste. They either work by nerve desensitization or tubule occlusion. There's also other things like tooth mousse that can help as well. And when we're looking at the evidence-based ingredients, I would look out for stannous fluoride, strontium acetate, arginine or calcium carbonate, and or calcium sodium phosphosilicate. And of course, if the home agents don't work, you then need to move on to more professional things like varnish, adhesive sealers, etc. So I think firstly, figure out, okay, does my patient have dentine hypersensitivity? Put that as a diagnosis, figure out why they've got it and fix those things, and then look at home factors and professionally applied agents that you can do. I think the other side of this conversation is as well is, how do you manage these patients in the chair? And it can be very tricky. You can't even do a simple supra PMPR without them jumping. And I just wanted to finish by kind of sharing a quick technique. It's not really evidence-based, but it works. And someone told me this literally like 15 years ago, and I've been doing it since. So when you've got a patient, they're healthy, you don't really need to numb them up, but they're super sensitive when you're doing your supra PMPR. Try rubbing prophy paste onto the tooth, because it blocks up the tubules, and the consistency is better than the toothpaste. Blocks it up enough for you to complete your treatment, and for some patients, that's made a huge difference. And then, of course, consider warming up your water in your ultrasonics. And if you really have to, of course, you've got local anesthetic at the end of the day. And we've got a few patients at our clinic where they're fine, they're stable, but we do have to give them full mouth LAs for them to be able to have comfortable care. So I think at the end of the day, you want to make sure your patient has a good experience, and dentine hypersensitivity can, in the chair, can really put someone off from coming back to the dentist. So come up with a little protocol of what you can do for these patients so we can help them and give them a good experience. Excellent. So this part of our podcast is one of my favorites. It's our case study section. And today it's a little bit different to normal. We've actually got someone from across the pond talking to us from the US. We have Katie Gill with us. And Katie, how long have I known you for? A good couple of years now.
My coworker and I, Marianne and I, did the hygiene course over in London about a year and a half ago now.
Yeah, and we've been in touch since, and it's great to be following your journey and everything you're doing. So I really wanted to get you onto the Perio School podcast, of course, to find out about cases in the US and how you treat it there, but also a more wider discussion about perio treatment and working as a hygienist in the USA. So for those of you who haven't seen Katie online yet, she is one of our Perio School ambassadors. But please, Katie, tell us a little bit more about yourself.
So thank you so much for the introduction, Dr. Reena. So like Dr. Reena said, I'm Katie Gill. I am a dental hygienist, and currently I'm a clinical instructor of periodontics at the University of Pittsburgh School of Dental Medicine in Pittsburgh, Pennsylvania, in the United States. And I graduated from university in 2010 with my degree in dental hygiene. I spent about 11 years in private practice, and during that time, I completed my master's degree in dental hygiene, which led me to the position that I'm in now in the perio department at Pitt. So here I work mainly with the perio residents that we have, and also the dental students more so than the hygiene students. I'm a little bit of everywhere, everything, but my focus is definitely with the dental students here.
Amazing. So I guess my first question would be, in terms of periodontal care in the US system, is it quite different to the UK and across the world? Like, what are the kind of differences?
I think that the UK and the US are definitely facing similar issues when it comes to patient care, although the sources might be a little bit different. From what I understand, the barrier in the UK is the NHS, ours
Correct.
being our private insurance systems. But I do think that how both of those are structured, we're having similar issues as far as reimbursement rates just aren't keeping up with the compensation rates,
Yeah.
plus the cost of running the practice. So
Right.
it's very difficult to be profitable as just a general dental office or as a periodontist. So
Okay.
in general, this has definitely resulted in doing more work in less time.
Okay.
So the work itself either suffers, or what we're having to do, and corporate dentistry has definitely contributed to that, especially here. It's what we often call a prophy mill, where we're basically just getting patients in as quickly as possible, regardless of their periodontal status and what they really truly need, just to be able to turn over that room faster and get more people through.
So yeah, unfortunately in the UK, it's especially on the NHS, it's very difficult. It's got better than it was, but it's very difficult to do parental care very well, and for the similar style of barriers, I guess. I guess one thing that I noticed when we met was obviously terminology is quite different in the US and UK, and some terminology is the same, but some is quite different. And you've recently made a translational guide for us, which I think is amazing. That's going to be going live soon. For those of our network that are in the US, you've translated what we use as terms for what you use, which I think is super helpful. So I think it might be good to just highlight some of the key differences on that.
Absolutely. I really enjoyed making that guide, not only because it gave me a chance to go through the entire Perio masterclass and kind of reassess and relive those things that we learned in the hygiene course last year, but also be able to share some of that information with other US hygienists. So I would say the first thing that I thought of, and I have to give a shout out to Nancy Bentley, who we both know, for
Yes.
helping me with some of this. There were definitely some things that I ran by her. One of the things that we talked about is when I say prophy or prophylaxis, what Nancy, who is a hygienist based in the UK, what she thinks of is polishing, whereas a prophy or prophylaxis here is the term that we use for a general cleaning on a healthy patient. It's
Right.
pretty much an insurance code that we use, and it involves not only polishing, but also removal of stain, calculus, and plaque from the enamel surfaces of the tooth. So it does still involve scaling, not just polishing, but that's definitely one of the terminologies that's a little bit different because anytime I would say prophy, she would wonder why I was only polishing someone's teeth, which isn't the
Hey.
case. And I think one of the bigger things that I found different with when I took the hygiene class or the hygiene course is that we're still using the term scaling and root planing here.
Okay.
I had never heard of the PMPR prior to attending your course, and I think it makes a lot of sense just because when you hear scaling and root planing, it often makes you believe that you have to have this perfectly smooth, this glassy
Exactly.
smooth cementum. And of course, we've learned that it doesn't, we certainly want it to be smooth, but we don't want to over instrument that
Yeah.
root surface. So
Correct.
I do think that PMPR uh, is a a better way of putting it.
Yeah.
But I will say that the second P in the PMPR stands for plaque.
Yeah.
So in my mind,
Right.
it almost makes it seem like, well, what about the stain? What about the calculus?
Yeah.
So I can see the pros and cons to both of those
Yeah.
terms, but that was definitely a big one. And then certainly how the BSP took the staging and grading recommendations from 2017
Yes.
and simplified those and definitely made those a bit user friendly.
Correct.
That is something that we do not have here in the US. We're still going by the AAP EFP
Yeah.
chart, which is very difficult to understand.
I
So
mean, I
I
say it all the time to our UK guys when I'm teaching, and I'm like, "You're so lucky we have this adopted version where it really is very straightforward and objective and very quick to do in practice." And yeah, I only wish the same that was the case for across the world, and the AAP adopted that as well. So but yeah, I guess there's different reasonings behind the complexity behind it. But I think for me, it's always like, how can we make things simple, especially for the people, in general practice doing the bulk of the work.
I think it makes a lot of sense. And I did a study not too long ago comparing the what you would actually get as far as extent, stage, and grade between the AAP EFP methodology and the
Okay.
BSP. And there were some slight differences, but overall
Really?
you got the same or a very similar result and
That's really
much,
interesting.
much faster with the BSP method.
Well, I never know. It could change.
Here's
um,
hoping.
what would surprise a UK hygienist most about practicing in the US?
I think that one of the things is that we have a lot of differences in the scope of our practice between
Okay.
states. So, what I may be able to provide for a patient here in Pennsylvania is going to be different than what I could provide for a patient, say, if I were working in the state right above us, New York.
Okay.
So, just those, even though it's not that far away, there could be major differences as far as whether or not I can give anesthesia, the type of supervision that I need to have, just because hygienists in the vast majority of states cannot practice independently. So,
Okay.
do I need the dentist to be in the practice with me? Do I need them in the building? Do I need them to be in a certain vicinity?
Sure.
That could vary from state to state. So you could have potentially 50 different ways of doing things, and each state has their own licensing body.
Right.
So you might be right on the border of two states. You might need to have two licenses.
Wow. So does that make it difficult though? If you graduated from one university and trained in a certain way, and then you're in a working then in a different state, or do all the universities train you to the same standard, and then you do different things in different states? How does it work?
They will train you to a different standard. For example, I attended university in the state of West Virginia.
Okay.
When I started university, hygienists in Pennsylvania could not administer local anesthesia. Now, luckily, they could in West Virginia, so I did learn that skill and was able to bring it here. But had it been the other way around,
Yeah.
I would not have actually learned that in university and been able to take that with me. So I would have had to take the class after the fact.
Oh, right. So then you have to do extra classes to then be able to work.
Right.
Wow. So you have to do different exams for different areas to work in
Correct.
the area. Wow. That's
Yes.
quite intense.
Also, I would say that hygienists can't diagnose periodontitis in the United States. I can't
Wow.
diagnose anything. So that's definitely a challenge just because essentially that's what I'm an expert in
Yeah.
is hygiene and periodontal disease. So that kind of goes along with the way that we do referrals and how there's that barrier and that challenge as well.
Did you feel confident when you graduated in terms of treating complex perio? Like what's generally like the level of confidence on what you're able to treat?
I feel that the new graduates are leaving school feeling much more confident managing perio patients than I
Great.
did. And that's not a reflection of where I went to school by the university I attended was absolutely wonderful, but it was also at a different time
Yeah.
where I think that we're focusing a lot more on not only doing all of our assessments, but using those assessments to interpret and determine what is the best course of action going forward.
Yes.
Whereas when I was in school and I did assessments, regardless of someone having a 3 millimeter pocket or a 7 millimeter pocket, it was the kind of thing you just got in there and cleaned it.
Okay.
So obviously, you would still be using the same types of methodology, the same instrumentation, but we didn't necessarily stage and grade that patient, first of all, because it was before that time.
Yeah.
And we weren't necessarily even calling it scaling and root planing. It was more just, we're cleaning deeper on this patient.
Right. Okay.
So when I got into private practice, I was used to, regardless of what the patient presented with, I was getting in there and cleaning it. And I think that that has changed significantly.
Okay.
However, there's certainly a lot of dental professionals, hygienists that graduated around the time that I did or prior to when I did, who are still doing what I was doing before and essentially doing what I would call a super cleaning
Okay.
and, you know, doing scaling and root planing or PMPR on a patient, yet calling it something that it's not, as far as a prophylaxis or just a general cleaning.
Yeah, interesting, interesting. Going on to cases, like, have you at the university seen any super interesting cases or any like surprising cases?
In the perio department, the past few years, we've definitely expanded. And as a department, we're doing a lot more clinical based research. So our
Okay,
residents, who are absolutely amazing, deal a lot with periimplantitis cases. So we have had quite a few patients over the last few years come
right.
in with various levels of periimplantitis, and it's very cool to see how
Hmm.
their treatment goes using different modalities. We've
Yeah.
been getting more behind the EMS airflow
Yes.
and utilizing that, which I know that you're a big advocate for,
I
and
think
Marianne and I as well. Yeah, it's wonderful. So it has been very cool to see, implants go from mobile or having. There was one just the other day, the patient had originally presented with a 9 millimeter pocket. It was 4 with no
Wow,
bleeding. So
fantastic.
Now, granted, they did do surgery with that patient, but it's really cool. Airflow is always the first step,
Yeah.
and it's been very cool to see a lot of those patients who may have otherwise lost that implant. We were able to not only salvage it but maintain it since
Yeah,
then.
it's such a big area now, isn't it? I think it's periimplantitis, and it's huge already, but it's going to be a real problem. I think could be our day to day work is just treating periimplantitis. So
Yes,
I think it's something to definitely get confident with assessing and treating, and also knowing where your limit is and where you need to involve other people. As you said, sometimes, often it is surgery based, and I like to always say, never promise the patient everything's going to be perfect. You're just prolonging the lifespan of that implant. You'll never get it perfect. It's always going to be a peri-implantitis case, whether it's stable or unstable. So
absolutely.
well, Katie, I could talk to you forever, but I know you've got to get to clinics and to help the residents. But just to say, I'm really looking forward to coming over there in June for our course together at the University of Pittsburgh. So if there are people listening from across the US, please do. Where's the best place they can find out more about it? I guess online. We can message either myself or Katie on Instagram, and we can send you the link. But we are going to be running a hands-on course for 2 days. We're going to be doing everything from the theory, from this communication side, the business side, and then the hands-on instrumentation side. So yeah, it'll be great to see some of you there who are, or you can make a holiday to the USA and come to our course. So yeah, Katie, thank you so much for your time, and look forward to connecting again soon.
Absolutely. Thank you so much for having me. Always a pleasure.
Thank you.
You're about to hear something really exciting. You know that we have launched the soft tissue course for the first time this year, and now you're going to have a little sneak peek into the teaching during the course. You're about to hear Dr. J and Dr. Devan giving recommendations to their delegates and suggesting what is the best way to perform different soft tissue surgeries. You will also hear Dr. Devan teaching, which is super unique because this course is happening only once a year, and the next one is not until next January.
So the cross, let's say you're going to do it on this side now, right? You would do exactly the same thing, take a bite whichever way you want, but instead of going in on the same side it came out, you go back to, what did I say, go in here, come out here, and then you go through here and come back through that one, yeah? And that will cross it over. So it's just which contact point you go through first, this is the only difference.
So you can see here, we've gone in, taken our graft, and we've nicked the artery. That's going to start bleeding out. First thing you do, firm pressure, because a lot of the time, firm pressure for a good 10, 15, 20 minutes, even 30 minutes can actually settle things down for you. But you don't want that patient to leave with an active bleed. Obviously, you want to make sure everything is settled down. So pressure doesn't work, and you've got quite a clear arterial bleed, which can be quite frightening, actually. But very manageable. So what we want to do is we want to suture things up. And the way we suture it up is, first of all, asking ourselves, well, where's the bleed coming from? It's going to be coming from the distal aspect. That's the way in which our palatal artery is coming forward. So we want to be taking our suture and we want to be working behind where we are, okay? And that suture is going to start to compress the tissue. So you've got to take quite a deep suture. And at this point, I would recommend if you've got 4O, even better if you've got 3O sutures, these are the ones because you need rope to basically compress everything. Okay? Rope. That's where you're putting it. But what you're essentially doing in terms of positioning of the graft is you're not going to be putting it through the graft. You're going to be putting it distal to the graft. But your suture has got to go like that, yeah? Because when you tie that off, what that will do is it will compress the vessels, yeah? So you've got to make sure you're going quite deep with your sutures. And it may not even be one suture that you need. You may need to put a couple in. And also if you're struggling to identify where the bleed's coming from, because sometimes what you can have is you can have a vessel coming in from this direction here. So you get the Pritchards or something like that, and you're putting firm pressure around your graft. You're trying to identify where's that vessel coming from. And that will then allow you to identify where you need to tie things off, okay? The coronally advanced flap, as other flaps are, they are known as pedicle flaps. So before, what we've been doing so far is what we call a free graft. you're completely taking the graft from its original donor site, freeing it completely, and it has to find a completely new blood supply where you've just put it and secured it in place. Therefore, it's called a free graft, okay? A pedicle graft is where you don't detach the graft completely from its recipient site, from its donor site, okay? So it will still be hanging on to where you've got it. And the advantage of that, obviously, is that you've got a blood supply. You've got a much better blood supply, which means that you've got the forgiveness when you're placing it over an avascular area, which is namely the root for root coverage, or if you're going to be pushing the boat on an implant for implant coverage in specific cases. And there's lots of different types of pedicle flaps out there. You've got sliding flap, that's the first one, and actually we're going to be doing a variant of that tomorrow. Modified sliding flap, coronally advanced flap, which is what we're going to be discussing now. And then when we start looking at multiple recession defects, you then got kind of Zacchelli, who's come in, and Massimo De Sanctis, where they kind of came up with very predictable ways in which to manipulate the papillae and move the tissue in the right way. Alongside that, you've got two-stage techniques, so we'll show you some examples of that tomorrow, but ultimately it's where you put a free gingival graft in first, so that you're creating the thickness of the tissue, and then you coronally advance the tissue afterwards. Bilaminar technique was introduced in the 90s. Now what this is where it's bilaminar, bi-layer technique. So you've got a pedicle flap, which is the bit you're releasing from the donor site, but underneath that you're adding an extra layer, and that layer is a connective tissue graft. Now it has to be de-epithelialized in theory. So you're taking the epithelium off, so you've just got this connective tissue filler, so to speak, and that's how it works. And we'll go through indications when you would consider a connective tissue graft and also where you would take it from. You've then got the laterally moved coronally advanced flap, so you're moving the flap, and if you've released it enough, you'll then lift it up as well. So you can move it in two different vectors. You can move it horizontally, and then you can also move it vertically as well. And that's all going to be, the movement of the flap is all going to be due to releasing the muscle off the inside of the mucosa, okay?
Our guest today is Dr. Victoria Sampson, an award-winning functional dentist and one of the leading voices in the evolving field of preventive and holistic dentistry. Victoria graduated from Barts in London with a strong foundation on the connection between oral health and systemic health. She has completed our diploma in periodontics a few years back, and over the years, her work has gained international recognition, including being shortlisted for Forbes 30 Under 30 in Science and Healthcare, the first dentist to actually achieve this. Alongside her clinical and research work, Victoria lectures globally and advises several dental and healthcare companies. And outside dentistry, she is very creative. She's also a DJ who creates music for her patients as well to enhance their experience in the dental chair. Victoria, so great to have you on the Perio School podcast.
Thank you so much for having me.
It's been so amazing following your journey and super proud of everything you're doing. So congratulations on all your achievements so far, and can't wait to see what you're doing next. This part of our podcast, we like to ask sort of quick fire questions on you as a person, some behind the scenes of your day to day. So I'll get started with, how do you usually start your day? What are your sort of non-negotiable habits?
Probably not the healthiest, but I have to have a coffee in the morning. Have to have a shower as well, like a hot shower, coffee. And I need to walk or cycle to work. Like if I'm just like on a bus or a tube, I'm just not right for the rest of the day.
So get the steps in early.
Yeah, I need some air. Otherwise, I'm like locked into a surgery all day. Oh, and then music. I also don't like speaking to anyone in the morning. I like to only listen to my music whilst I'm on going on my way to work.
And how do you take your coffee?
Oh, flat white.
Nice, nice. And what's stocked in your fridge at home? What's your fuel that keeps you going on busy days?
Baby bells or just
Oh,
cheese?
nice.
Dates, almond butter, sometimes protein bars, boiled eggs. I know it's a bit weird, but it keeps me going. I would say that's it.
Yeah, nice. Lots of protein. So for you, what is a typical working day? I know it varies across the week, but just typically, what sort of things would you be doing?
So at the moment, I split my time clinically. So I work 2 to 3 days, sorry, 3 days a week clinically, and then 2 days a week, like on the lab, on research and kind of the microbiome side of things. But if we were looking at just like a traditional day where I may be at the clinic, I will wake up, I'll go to the gym and work out, and then I'll also do about 45 minutes of like emails and stuff for the microbiome test in the lab because every day is a new day. And then I'll go to work. I will do all my clinical work. Sometimes have a meeting during my lunchtime. Then I finish work around 6. Then I have to do all of the like cashing up and everything for the clinic. And then I will go home and eat and pass out.
Yeah, I think that's the kind of behind the scenes of owning a business, and you're doing multiple things as well. Like, it sometimes looks glamorous, but actually behind the scenes, it's so much hard work, and it's like you never switch off, which is
Literally.
critical. What keeps you going in the day? Like, what is something that you just can't live without that keeps you energized? Because every time I see you, you're full of energy. You're always giving 100%. Is there anything particular that keeps you going?
Um, Probably coffee. It's just like I do like stay very hydrated and I drink quite a lot of coffee throughout the day. Like I can't without it.
Yeah, yeah. So you've done quite a lot in your career already, which is super impressive. What's been the highlight so far?
I don't know. I would say I think joining the advisory board for Harvard was a really, really big thing for me in particular because I was going through a lot at the time with a lot of the work that I do. Some people don't love what I'm doing, and with every kind of innovation comes, skepticism and criticism, which I appreciate. And I understand that that's part and parcel of bringing something new to the market. And we need that to make sure that everything that we do is evidence-based and correct. But I was kind of feeling a little bit like, am I doing the right thing? What's wrong? Like, I was having definitely a lot of doubts. So achieving that was a really, really big achievement for me. And I'm the youngest on the board, and
Amazing.
being able to contribute to, research and to advice on how to build Harvard's kind of innovation up it's just a huge, huge honor for me.
That's amazing. And you've got a close interest in sort of, as you said, oral health, systemic health. What drove your interest in that? Is it something you've always been interested in? Or was it a certain paper or something happened that then made you think, okay, this is a real interest of mine?
It was a couple of things. I think it started much earlier on. I went to Stockholm for a year during my kind of university, and I went to the Karolinska Institute, and there they really did a lot of work on diabetes and gum disease and the connections there. They were doing already a lot on saliva testing. So I saw a whole different world to dentistry from my fourth year, and I was like, whoa, this is cool. And then my mom fell really ill, actually, and that really changed my perspective on like what health meant, and I think that's where the more holistic and functional side of things came because, her doctors were saying one thing. And then I was thinking, well, surely we could help with nutrition. And I started like learning a lot more on supplementation, nutrition, on, auxiliary treatments, even acupuncture, on Reiki, like all of that, mainly because of my mother. But it's still, it was in the back of my mind, and I probably was, acting in my life that way, but I wasn't really collaborating with my dentistry on that. But then COVID happened, and then I started writing a lot of research, which was connecting the mouth to the rest of the body and trying to understand that poor oral health could increase the risk of COVID complications. And I think that's where like all of the stars aligned, where I was like, oh my God, like mouth body connections, functional health, nutrition, like everything is connected. And then the final piece of the puzzle was like, how do you test this and how can you make things better, was through like microbiome testing and having quantitative data, trying to just combine everything and join the dots together.
And the paper you released on the COVID findings was, I think that was a real key paper that people still quote and reference. So yeah, that was an amazing contribution.
Thank you.
What's been the most exciting development you've seen in dentistry recently? Because you're at the forefront of all these new developments. Is anything particularly that you're like, oh, I need to keep my eye on that, or this is going to be big?
So I think peptides and exosomes are going to be like the new thing in dentistry. It's already made a huge kind of movement in regenerative and longevity and more preventative medicine. And I think dentistry always follows like 5 to 10 years behind. We already use some peptides in dentistry like Curodont Repair. Even tooth mousse, I didn't realize, but it's also a peptide. And I
Right.
think that we're going to start seeing, there's research, and hopefully one day we're going to have evidence to maybe look at other peptides and how to regenerate periodontal tissues, how to accelerate wound healing. Even with exosomes, like I think it's going to open a whole new world to prevention and improving patients like symptoms post surgery and all of that. So I think that's what I'm like every day I'm like refreshing PubMed. I'm like, anyone come out with anything yet?
Oh wow, that's definitely one to watch. How do you stay curious? Because you're always kind of researching new things, developing new things. What keeps you curious on learning more and motivated to learn more?
I think, well, I've always been one of those annoyingly curious people who just always likes to ask lots of questions, which was annoying, I think, for my parents. But it means that I've never, I don't settle for like this is how you do it. I'm like, but surely there's a better way of doing this.
Yeah,
Then also my patients, honestly, they teach me so much. Like, I mean, they're bringing these toothpaste in and are like, oh, I read that this has this percentage of that, and so
yeah,
I have to be on my toes because a lot of these patients seek me because they think I'm like, innovative and I'm at the front of all of this.
yeah,
And then I'm like, oh my God, like I need to actually like live up to this.
yeah,
So they definitely keep me curious. And then also another thing which I'm very grateful for is the fact that I get to travel a lot for lecturing. And so you start to see what other countries are doing. And I think
yes,
sometimes in the UK, you kind of become a little bit siloed into like, this is what we do in the UK. And then you go
yeah,
to like Portugal, Brazil, you learn about what they're doing in Japan, and you're like, oh my God, like dentistry is very different in other countries. And you start to bring in all of that. So, like peptides and exosomes, I learned that in the US. Like, all of these things are kind of coming from different countries.
yeah. And I think it is eye opening when you travel the world and see different approaches. And yeah, it definitely makes you more enthusiastic about what you're developing and bringing forward. So I have a couple of non-dental questions now to finish. So, okay, what's one thing people would be surprised to learn about you?
Whoa.
You
Surprised to learn about me. I don't know if it's that surprising, but I can't drive.
can't
I've
drive.
I've failed my driving test like 2, 3 times now, and I still can't drive. And it's like my mother's like biggest like thing. She's like literally every day, I'm like, oh mom, I did this, or oh mom, like look, I got into this, and I just published that or whatever. And she's like, but you still can't drive. So so maybe that, I guess.
And I mentioned you're a DJ, which I think is super cool. How did music become a part of your essentially your day to day, and because you're bringing it into your dental practice as well?
Well, I've always been like that musical one, you go to a party and everyone's like, "Oh, who's going to play the music?" They always would like give me the phone or whatever. And then I got into kind of mixing and doing and going more into the DJing side of things. But I was also becoming a dentist and I was like, "Well, this like doesn't really work very well." So that was more of a hobby.
Yeah,
But music personally for me is it makes or breaks my day. Honestly, I can be crying and I can be so upset, and then I listen to a fantastic song and it will turn my day around. And it's
yeah,
like that's my love language. Like I send people songs because it reminds me of them, or
yeah,
so I then brought that into work because I realized that music has the power to calm people down, to take people to a completely different universe. And
yes.
so I started building playlists like based on different genres, and I'll be like, okay, this is, I mean, you would laugh at all the names of the playlist, but it's like this is like deep house root canal music chilled, and then like there's like heart, heavy, no, not heavy, but like soft rock. There's acoustics. I've even got one called Sad Dentistry, which is for composite bonding because I like to listen to very like sad acoustic woman complaining about love whilst I'm doing composite bonding. So, and I just realized that it like once I started doing that, patients would come back and be like, wow, like I forgot that I was even in the dental chair. That was amazing. And so it's just kind of kept me going.
I want to see your Perio playlist. Yeah, for some
Weirdly, I listen to disco music when I'm doing like a proper like, deep clean. It's like quite intense disco music. It keeps me going, I need to like feel like I'm,
Yeah, yeah. What's one book, podcast, or resource that has shaped how you think
in dentistry or just generally.
in general?
There's a book, it's called The Defining Decade.
Yeah.
And it really changed my life, honestly. My old boss gave it to me when I started working at her clinic, and it basically shows you about how like important your 20s are. I would argue now your 30s too, but just that like everything that you do now is building blocks for your future. And just like how to connect to people. It really, yeah, I would strongly recommend everyone read that.
We'll definitely check it out. And then finally, if you could swap careers for a day, what would you choose? Or would you choose anything different?
Mm, I don't know. I flip-flop. There's a few different things I would do. One would be a DJ because obviously that would be awesome. The
Yeah.
second would be, I know it sounds really silly, but sometimes I am very envious of my friends who work from home and they've got like,
Yeah.
like a nice 9 to 5 job, and they're able to go and do like Pilates in the morning and cook their food in the kitchen. And I'm like, I'm never home, like literally never home. But deep down, I think I love what I do. And I think that one of the beauties of dentistry is that you can do as much or as little as you want. You can, you could be a very, very traditional, old-fashioned dentist who doesn't want to do anything innovative. That's
Yeah.
entirely fine. You could be
Yeah.
a dentist who wants to like constantly push the boundaries and try new things out. Like, so it is very much like what you want to do with it, which I love.
Amazing. Well, listen, Victoria, I know you're between patients, so thank you so much for taking the time from your busy day. What's next for you? What can we look forward to seeing in terms of anything exciting, any exciting projects you can reveal?
So we are in the process of publishing quite a lot of research at the moment with our
Yeah.
oral microbiome test. So we've collected hundreds of samples of patients, and we're finally actually able to publish some of that data, which we're very excited about. And then we're also we're coming up with a new version of our test, which has been refined using our algorithm. So a lot of really, really exciting things happening. And I think that the kind of microbiome testing future is just at its very beginning. So I'm really excited to see where it takes us.
Amazing. Thank you so much and look forward to speaking soon.
Thank you.
This season of the podcast is sponsored by Kiroku, an AI assistant built specifically for dental professionals and one we've used for years. Kiroku listens to your appointments and turns chairside conversations into accurate clinical notes, referral letters, and treatment plans in minutes. What used to take hours now happens straight after the appointment. No late evenings catching up on notes. You can start a free trial at trykiroku.com. And if you'd like exclusive discounted access, email us at hello@perio.school.